Here are my credentials. It is my role as Director of Cardiopulmonary Exercise Testing at the Mayo Clinic in Rochester that energizes today's presentation. No disclosures. Our learning objectives are to discuss the process of evaluating patients with heart failure for transplant using exemplary cases, and to describe the role of cardiopulmonary exercise testing in that evaluation. Here's our first case, collapse at the finish line. This young athletic male presented to us in September of 2017 at age 19 for advice on management post-cardiac arrest. In the spring of 2017, as a high school senior, he had a cardiac arrest during a 100-meter dash. Actually, at the end of the race, he collapsed at the finish line, underwent CPR, and got resuscitated by 2 AED shocks. 11 days later, he received an ICD implant. And subsequent exercise test showed a lot of PVCs beginning in about 8 minutes of exercise. The test was otherwise unremarkable, but several hours after the test, he had another VT episode, received a single shock which did not terminate the VT, but fortunately it resolved spontaneously after 30 seconds. He was started on beta blocker Nadolol and heavily restricted after these events. A sample was sent off for genetic analysis. All of the genes for hypertrophic cardiomyopathy were negative. There were 4 variants of uncertain significance identified in 3 separate arrhythmia categories: CPVT, that's catecholaminergic polymorphic ventricular tachycardia, arrhythmogenic right ventricular cardiomyopathy, and Brugada syndrome. However, again, I must emphasize that these were all variants of uncertain significance. So we're left without a formal diagnosis. Maybe this is CPVT, maybe it's PVC-triggered VF. So CPVT, catecholaminergic polymorphic ventricular tachycardia, is a genetic disorder affecting the calcium channels. It affects only 1 in 10,000 individuals, but accounts for 15% of cardiac deaths in young people. Manifests itself during the first or second decade of life generally, 60% of the first events occurring between age 12 and 20, as they did for our index patient here, triggered by emotional stress or exercise. There are no macrostructural defects. 5 types of CPVT. Genetics are known in 4 types. We're concerned that our case might have CPVT1 because of an RYR2 mutation, but again, it's of uncertain significance. We treat apamil. Flecainide is the second drug option, bilateral thoracoscopic sympathectomy, ICD. The ICD can cause a VT storm. Patient gets a VT, gets a shock, catecholamines go up, gets another VT, another shock, and this may go on for some time. So back to our case presentation. He has a normal echocardiogram, some features perhaps of athletic heart, but nothing pathologic. Here's his first stress test. Normal resting electrocardiogram. Upon standing, he has some ventricular bigeminy. This would be unusual in CPVT, but not unheard of. At low levels of exercise, he goes back into bigeminy and remains in bigeminy throughout the remainder of the test, quickly resolving. If we look at his cardiopulmonary exercise testing data, we can see that the VO2, that's the green line here, the VO2 goes up nicely, almost reaches the predictive value despite being on Nadolol. Good effort. We like the respiratory exchange ratio to be at least 1.1. Heart rate near maximal, again, slightly attenuated with beta blockade. Gas exchange in the lungs, measured by the VEV-CO2 slope, is completely normal. Anything less than 30 would be normal, so there's no heart failure here. Oxygen pulse, an analog of the stroke volume, rises normally during exercise. Let's continue with his timeline. You see his initial events in spring of 17. Now, 2 years later, he has another cardiac arrest while weightlifting and undergoes the left cardiac sympathetic denervation shown here in schematic. He came back to Mayo and we repeated his exercise test. Again, a normal resting electrocardiogram with no ectopy. Ventricular bigeminy onset at 50 seconds of exercise, even earlier than before, and continues throughout the test, now with some couplets. Interestingly, all of the PVCs monomorphic. We don't see any polymorphic forms here. And this time it takes quite a bit of time to recover. Here at almost 3 minutes post-exercise, we're still in ventricular bigeminy, finally resolves. Exercise capacity is reduced in proportion to the reduction in heart rate as the Nadolol dose, as you see, has been doubled. Test still looks like good cardiac function, no heart failure. So here we are, June 2019. He has failed multiple drugs, Nadolol, flecainide, verapamil, mexiletine, and sympathetic denervation, still has frequent ventricular ectopy. What next? Well, it was decided that maybe this isn't CPVT at all, but rather PVC-triggered VT and VF. A VT ablation was attempted, unsuccessful. He had recurrent and frequent VT. 2 days later, a second ablation was attempted, which unfortunately threw him into incessant VT. He was placed on ECMO, and fortunately, a heart was found 2 days later, or 12 days later, he had a heart transplant. Ejection fraction remained normal throughout. Here's some event monitor strips after the first ablation, and here after the second, you see ventricular fibrillation has become his persistent rhythm. After his transplant, he's had a slow recovery of his exercise capacity. Heart rate now up to 141, a VO2 max 38.7, not quite back to where he was initially, but hopefully he's on the way. He's the only case of CPVT as a reason for transplant that I was able to find in our recent database. Let's look at the second case now, postpartum fatigue. Another young patient, 26 years old, She presents in January of 2006 for evaluation, fatigue, chest discomfort, and anxiety. Her symptoms began 2 weeks before the delivery of her first and only child, and that was in 2004, about 2 years prior to this visit. She was initially treated with guideline-directed medical therapy, which caused orthostatic hypotension. Drugs were gradually all stopped, and her symptoms resolved. Interestingly, she was diagnosed with WPW, Wolff-Parkinson-White syndrome, and had a history of 3 RF ablations. Family history, not relevant at all to the case. As she presents with us, we can see that despite the 3 ablations, she still has WPW. Heart function was evaluated by cardiac MRI. LVEF was estimated or calculated at 37%. I'll highlight some of the other findings. Structural heart disease, as well as a lot of delayed gadolinium enhancement. You see, reduced LV function overall, inferior wall thinned and akinetic or severely hypokinetic, delayed enhancement in those segments and all along the endocardium. Unlikely this would be a single coronary artery distribution, but multiple infarction was entertained, as well as a more generalized myocarditis. Again, ejection fraction approximately 37%. Interestingly, some prominence of the septum and anterior wall, despite the dilated LV. The issue of multivessel coronary disease or multivessel spontaneous coronary artery dissection was raised. Coronary angiogram, however, was unremarkable, gave no evidence of atherosclerosis or SCAD. So at the end of this visit, she has a dilated cardiomyopathy, but etiology is unclear. No evidence that this is due to spontaneous coronary artery dissection or coronary artery disease. We assumed at that time that the WPW was an independent condition, metoprolol succinate plus or minus diuretic recommended. She returned about 6.5 years later, now age 32. This was a transfer to St. Mary's. She was in decompensated heart failure. In the meantime, she had acquired a CRT-D device, defibrillator, and resynchronization therapy by ventricular pacing. She was on 2 inotropic agents, dopamine and dobutamine, which were initiated locally. From her chest x-ray, you can see the device that she has acquired and also evidence of pulmonary venous hypertension consistent with congestive heart failure. Echocardiogram at this time shows an EF estimated of 14%. Compared to the January 2006 echo. EF wasn't particularly good there, but it's deteriorated quite a bit more. Hospital course included implantation of an LVAD HeartMate 2 device. Remember, this is 2012. And she improved and was sent off to exercise in cardiac rehabilitation. At this point, we began to follow her progress through serial cardiopulmonary exercise testing. Her initial peak VO2 was only 12.8, should be about 35 at this time, so she's 37% of predicted. VEVCO2 slope, however, was normal. She improved over the next couple of years. Ejection fraction stabilized at 25%. Peak VO2 increased to 15, and VEVCO2 was still normal. Now, that's only 46% of predicted, but it's above the level that we would consider transplant necessary. However, April of 2016, she's 36 now, and EF dropped a little more, VO2 dropped, VEVCO2 went up. What was happening here? Well, let's look at that cardiopulmonary exercise test. You can see she's now mostly AV, A and bi-V paced. However, there's still some intrinsic conduction with pre-excitation and left bundle branch block. Here's the VO2 compared to predicted. Very little increase in heart rate. Near maximal effort on the test. VEVCO2 slope in the gray area toward the upper limit of normal, but not severely elevated. Reason for the deterioration appeared to be right heart failure, which is one of the common complications with LVAD. It's got enlarged RV, reduced function, and significant tricuspid regurgitation. January of 2017, she underwent heart transplantation. You can see she's had quite a good follow-up since then, trending upward in terms of her peak VO2 and downward in terms of her VEVCO2 until this most recent CPET. At this point, we hope that's not part of a trend, but maybe just a little temporary blip. She did not achieve her predicted VO2, best so far, 73%, but significantly better than pre-transplant. Her limited heart rate reserve and the pre-transplant muscle loss are reasons for not achieving predicted VO2. So you're asking, what was the diagnosis? Well, the heart was sent off for pathology, came back suggesting Fabry disease. Findings included biventricular hypertrophy and dilatation and myocyte vacuolization consistent with this disease. However, she did not present in a manner suggesting Fabry disease. Don't know how familiar you are with this condition, but there are a number of very characteristic findings which she lacked, and of course she didn't present at all until she was in her mid-20s. So next step, sent off a specimen for genetic analysis. It came back positive for the mutation in the LAMP2 gene, which codes for Danon disease. Also, multisystem glycogen storage disease. It's on the X chromosome, so that effects are typically milder in women than men, but if untreated, age at death in women is a median of 34 years. Males, because they have no good X chromosome to balance out, they have skeletal myopathies, intellectual disability, and a more early appearing and aggressive cardiomyopathy age at death if untreated, 19 years. Now, unfortunately, the one child she had was a boy, but he's alive and healthy, has no signs of any of these findings, and he's 13 years old at the time of his mother's transplant. So unlikely he has inherited this mutation, but we do suggest that her first-degree relatives all undergo genetic analysis. As far as I'm aware, Danon disease is a single case as a cause for transplant in our recent database. Take-home points. There are many causes of heart failure ultimately requiring transplant. Heart failure requiring transplant may also affect young athletes. The exercise test is an important tool for assisting in the timing of transplant while improving survival and reducing symptoms during activities of daily living does not generally restore normal exercise capacity, despite the fact that everybody goes to cardiac rehab. Thank you for your attention.